not gonna talk about it, but we're gonna talk a lot about the non-syndromic type. As we start in the non-syndromic type, we'll find diverse types of the cleft actually, whether it's incomplete from just submucous to incomplete cleft lip and nose, and the complete cleft lip, which its diversity in shapes, the bilateral, and even the cleft palate. You can find starting from the submucous cleft to the bifid uvula, complete cleft, and the bilateral complete cleft lip and palate. That's why we needed the classification. Why would we need the classification? Because the classification is the method of communication between different specialties and the method to evaluate your work along the years. First classification was the Veau classification, which was a very simple one, just classifying anatomically, starting from the hard palate, soft palate as type 1 till the hard palate, and if it extends to the incisor foramen, it's type 2. And if it's complete unilateral cleft lip, it's type 3, and type 4. It's not enough to paint a different diversity as we see. Sometimes hard palate and cleft of the soft palate alone. So this does not work for the Veau classification. That's why we needed another one, which was the stripe type or Kernahan classification, which divide the cleft into the right and left side, starting from the lip nose, then the alveolus, the hard palate is the incisor foramen, then the soft palate into 8 and 9. It was written in digits because in the early use of this classification was trying to get it into digital, think as the computers was used in the early 70s. We have our own model for the files of the patient, where we added to it even the type of operation, so we can get easily the information of the patient before and after the operation. And I hope everyone can get and use this form, and if you just email me, I can send it to you. What the aim of our cleft is to get the level of excellence, but this will need multi-stage surgery. We need to practice in a cleft care center where we have the personnel, equipment, will, and much more important is the devotion. It's a multidisciplinary approach. You need a plastic or cleft or maxillofacial surgeon, whatever you call, because there's a gray zone where different specialties do surgery, but we need also the other specialties as the pediatrician, the anesthesiologist, the orthodontist, the ENT, speech pathologist, a maxillofacial surgeon, and also the pediatric psychiatrist, geneticist, and a craniofacial nurse. Also, the non-medical specialties are important. We need the photography to assess our results, use the models, and as you know, most of the patients are poor, so we need a social worker to find a fund for them. As you go into cleft, you found many directions, and the aim to reach one goal, which is the patient satisfaction. So in every stage, you find a controversy. That's the problem of cleft, that all over the world, there are different ways to do the surgery, different way to treat the patient, different protocols.
So, I'm sorry, can I stop you for a second?
What I'm going to present is our experience in the cleft, and that's what we do. Okay.
We have a bit of a connection problem. I know we didn't get yet to the slides, but maybe if we work on that for now, it will work later on. You could go ahead with your slides, but maybe work on the connection problem as well, if that's possible.
If you have do you have the problem in the sound or in the slides?
No, in the sound, your audio. Your voice is a bit sluggish because of the connection problem. So maybe improving the connection, working on it would correct everything.
Okay, just give me a few seconds. I try to change. Is it better now?
Yes, much better. Yes, much better. You can go ahead, Dr. Hassan. Dr. Mamdouh, can you hear me? Well, it's a good thing that we caught it early in the basic slides. This will be fixed soon. Please, if anyone has any question, place it in the chat department. If anyone has a personal question or would like to ask it himself or herself, just raise a hand at the end at the discussion point, and you will be given time to ask your question personally. Maybe for now, I will start one of our polls. I know it's a bit soon, but maybe we'll use it this time.
Yes, Ahmed, you can start the first question.
So please go ahead. Choose your best answer, the one you use it in your procedure and work. There are 3 questions regarding the cleft lip. So when you're done with one, just choose an answer and we'll shift to the other one. If you're not done yet with the poll, just keep it on the side and don't close it until you're sure of your answer. Just keep it on the side. You could move it to the side until you're sure of your answer. Meanwhile, Dr. ممدوح هل سامعني؟
الو
ايوه انا سامع حضرتك، هل سامعني؟
الو
ايوه يا دكتور ممدوح سامعين حضرتك.
انا كده سامعك
بس في problem still في الساوند.
انت سامعني؟
احنا سامعين حضرتك بس still a bit sluggish, but we could work with that if that's the best you could achieve.
طيب,
that's okay as well.
معلش انا بغير والله بين كذا كونكشن عشان لما بقطع.
مفيش مشاكل عشان احنا الوقت فعلا ما يجريش مننا فهاكي go ahead. You could just go ahead. هو كده الصوت catch up to the slides. It's okay.
And this is the third connection that I have, and okay?
Well, that's okay.
All right. Okay. Our protocol is following the so our protocol is following the one used by the American Cleft Palate Association and the International Institute for Cleft Palate. And from our experience for more than 5, the first 3 months, our main concern is we start by the feeding. We use a routine for all our patients. Then at bilateral cleft, we use a stage repair,
Okay, Dr. Mamdouh, I'll call you to fix this. I'll call you to fix this. I'm sorry everyone for the delay, but we'll be going on soon.
Can you add another question, Ahmed?
Okay, so everyone, I hope everyone is done with this poll. So maybe we'll go on with the other one.